on the collagen of the cornea. And if you know the structure of the cornea and exactly how our collagen, sometimes we can treat with, this is simple incisions, myopia till 12 diopters. And Dr. Lombardi here, I saw his patients, he had patients at -90, and then became also metropic.
It performed around 500,000 operations on RK, and the average they corrected was 6 diopters. So I tried to thank my master, trying to see till which limit the technique of RK could arrive if pushed carefully on. I could reach 21 diopters of correction and made a metropic eye, and the eye that I made a metropic, the 21 diopters, was not one of my patients, was Professor Dossi in Turin patient that is sent to me, so is without any discussion that the 21 diopter were achieved. So those times I was correcting severe myopic cases using only radial keratotomy. This is to point out 2 things. First, that what normally I say is true. Second, that I could have been in the possibility to study the technique to limit where no other surgeon in the world has never arrived. So to make you understand, from 6 to 20 you have a difference of 14 diopters. If you want to know the measure in millimeters, it's enough that you divide per 2.8 millimeter, and you will have every 2.8 diopters is 1 millimeter. So you can calculate how many millimeters of flattening of the cornea I could reach. So knowing this technique so well, I started to do keratoconus. And this was 1984. I was in Fyodorov in 1980. So I started to do radial keratotomy. And I was doing symmetric radial keratotomy on keratoconus patient. This in 1984. And making the radial keratotomy symmetric, the whole cornea, the patient had an improvement, but they were not happy because the diffraction of the light, the double vision, everything was very similar to before the operation, but they improved the myopia correction. Now, I didn't understand in the moment why, but when I saw the first map, and the first corneal map I saw in 1986, I understood immediately where I was wrong. I was copying the same asymmetrical defect of the keratoconus, just a bit lower than the curvature that he had before, but the defect was exactly the same. So when I saw the first map and I saw a keratoconus, first time in my life I could see the curvature of keratoconus, we had only to imagine before that how could be a keratoconus, I understood that I had to change my surgery from symmetric to asymmetric, because the keratoconus is an asymmetric sickness of the cornea, and the deformation of the cornea is only on one part of the whole cornea. So I had to modify only that part. The results were immediate and incredible. The people was happy, they could start to see as normal people, they were satisfied with the glasses that they could not use before, and the solution was there. I understood that the solution was there. 1987. Now, this is the cornea from Professor Kaufman book. Very beautiful book on the cornea. And my friend Margarita MacDonald made with him. And you arrive to a chapter where is corneal radial wrinkling. And the pictures I found were incredible. This is an eye under a hard contact lens, exactly orthokeratoprothesis, that are lenses that I used to be wearied in the night normally, and they compress the cornea in the center. And the eye, if one sees the feature and doesn't know that there are wrinkles, he believes that it has been under a radial keratotomy. And you can see how many wrinkles is in the cornea. Now, this is a fantastic photo because I didn't find at the beginning. I find only recently. So this can give you the exact idea of what the nature will do if you try to compress the cornea to reduce the curvature ray. So the cornea, if you want to compress the cornea, really pushing the cornea, and the orthokeratoprothesis really is like a finger that pushes the cornea all the night, you know, inside, the cornea will modify itself spontaneously, making wrinkles. You know wrinkles? Aging wrinkles. And these wrinkles, after everybody can look to the photos, the wrinkles look very like incisions. What is a result of a corneal radial incisions. So this is something that will explain you why the cornea under the radial keratotomy, reverse, can be flattened by the scars produced by the radial keratotomy. So you see the incisions. This is the design of the classic asymmetric radial keratotomy, not the mini. The mini is from here to there, half. Okay? The incisions go from 1.75 till 2 millimeters only. And the diameter from the incision to the upper part is included into 7.5, 8 maximum millimeter. So, from here to the same distance on the opposite of the pupil, 7.5, 8 millimeter. It is very important, this measure. Why is important? Because the criticism I told you before, that was not possible to perform safely a corneal transplant in an already operated or minier KI is not true. Because, as the colleague can confirm, the operation normally is performed for from 8, better 830, 9, 930 millimeters diameter of the cornea. I'm wrong? From 8 to 930? Okay. So you see the size of the optical zone that I interest with my surgery is into the ablated part of the cornea in case of a lucky need of a corneal transplant. This is a sample of eyes that we catch it from the file and we put on a table to make the work. Can you stop here? So you see there are technical contraindications that in the time running they have been expanded. As you see, pachymetry, thickness, equal no less than 250. In fact, I have here from 1 to 2 patients that had a cornea less than that measure. Eyes keratotomy not over 60 K reading, curvature reading. I use the diopters because I've been schooled in diopters. I saw you see the millimeters. I think it's more correct your system, but maybe I'm too old to change. I'm still using the keratometry. The third point is very important. Central thick leucomas on the visual axis after e